Good day everyone. Today's video will be about tropical sprue and environmental enteric dysfunction. These two diseases or syndromes are a big controversy in the world of infectious disease and intestinal infections, as a lot of physicians don't agree with their existence and don't think that disease should be classified within these two diagnoses. But the characteristics of these two diagnostic entities are real and people suffer from it. How to correctly diagnose it and how to correctly classify it is up to the scientific community, but as long as they don't agree, we will use the most popular classification and diagnosis, which is the classification into tropical sprue and environmental enteric dysfunction. And we start by an overview. There are two syndromes with unclear origins, but they share some similarities and have distinct features. Starting by tropical sprue. It has been recognized since ancient times. Some mentions go back as to the 2nd and 3rd century AD, and one of the first mentions was from Roman expedition into the Sahara and into the African Sahel. And some other but less reliable descriptions are Indian and in Barbados by Hillary in 1747. The term sprue originated from the word sprau, which referred to a persistent diarrheal disease similar to celiac disease. It has a Dutch origin, since Barbados by that time used to be in the Dutch sphere of influence. Knowledge about the causes and pathogenesis of sprue have advanced a bit during and after the outbreaks in World War II, when we had mass mobilization of people from other areas into the tropical areas, and there was a small distinction between celiac sprue or celiac disease and tropical sprue, which became evident in early 1970. If we talk about environmental enteric dysfunction, it used to be referred to tropical or environmental enteropathy, and now it's known as EED. It indicates functional deficit associated with histopathological changes in the small intestine, where the villus of our intestine will be blunt. We will not have this brush-like structure anymore. It will be more smooth intestinal structure, and the crypt will undergo hyperplasia, and we will have lymphocytic infiltration. It affects both young children and adults in resource-limited areas. The functional defects associated with EED increase intestinal permeability and gut barrier function, which leads to malabsorption, intestinal injury, and repair, immune activation, and chronic inflammation, which exactly from these parts is the main cause of the pathogenesis, is under debate. Effort to reduce childhood diarrhea through various interventions have resulted in a significant decline in death, but no stunting rates, which suggests that chronic inflammation in the small intestine may contribute to impaired linear growth in these individuals. If we talk about exposure or epidemiology, the tropical sprue is predominantly found in specific geographic areas within the tropics, such as Asia and the Caribbean islands. High-risk areas for tropical sprue include northern South America, especially Venezuela, Colombia, the Indian subcontinent from the Himalayas to the south, Myanmar, Philippines, and isolated regions in Africa and the Middle East. It is more common in adults, although cases have been documented in all age groups. It is relatively rare in very young children, and this is possibly due to the protective effects of breastfeeding. In some instances, tropical sprue has shown patterns of epidemic outbreaks within families or villages, suggesting a possible underlying infectious cause. Seasonal variation have been observed, with increased rates of tropical sprue occurring during specific periods, indicating a potential seasonal influence, which may also indicate us a little bit towards an infectious agent. It can also affect expatriates living in endemic areas and may occur in short-term travelers into these areas. If we talk about EED, it is more prevalent in children than tropical sprue and is associated with regions where hygiene practices and access to clean water and sanitation and hygiene facilities are inadequate. It is commonly found in low and middle income countries, particularly in sub-Saharan Africa, South Asia, and South America. Children under the age of 5 and adults are both affected by EED. The main clinical features of tropical sprue are non-specific and reflect the symptoms of malabsorption due to changes in hygiene, improved medical care, and access to clean water supplies. The frequency and severity of malabsorption may be decreasing. The diagnosis of sprue is often made at a stage when the presentation is subtle compared to the more severe disease seen in the past. Common symptoms include prolonged diarrhea, abdominal cramping, anorexia, and weight loss. Nausea may also be present, but not always. And this can indicate us into a more inflammatory process going on. Malabsorption of specific nutrients can lead to peripheral edema, glossitis, which is inflammation of the tongue, stomatitis, inflammation of the mouth, and dermatitis. This also indicates into a more epithelial dysfunction state and can indicate us into a more autoimmune situation or more autoimmune condition. Fever may occur at the onset of sprue related diarrhea, especially in Asia, but it rarely persists throughout the course of the disease. Some speculate that this is because when we have sprue, we have dysfunction of the barrier, then we will have facultative pathogenic microflora of the gut, disrupting the immune tolerance state within the microbiota and shifting it a bit toward the inflammatory side. Then when we go back into this state of equilibrium and immune tolerance, the fever will go away. The onset of tropical sprue is usually associated with an acute episode of diarrhea that becomes prolonged. It is less commonly characterized by an insidious onset. Patients often experience crampy abdominal pain, multiple loose stools with mucus, worsening symptoms after consuming foods, nausea, bloating, decreased appetite, and decreased oral intake may also be reported. Malabsorption of specific nutrients can result in lactose intolerance, anemia, which can convert from macrocytic to microcytic, impaired absorption of calcium, vitamin D, magnesium, leading to osteopenia, and the macrocytic diarrhea, which is usually caused by B12 deficiencies, will later develop into iron deficiency anemias, where we will have microcytic anemias. The clinical features of environmental enteric dysfunction: there are subclinical disease associated with diarrhea, enteric infection, linear growth faltering, stunting in children, and physical and cognitive impairment, especially in long term and in small children. There is no single clinical feature that is specific to EED to compare it to other gastrointestinal infections. The pathogenesis of tropical sprue, or what we may know about it at the current stage. First of all, the role of enteric infections. First, we have the initiation. It often begins with an episode of acute diarrheal disease. The disease shows an epidemic and seasonal nature, and it responds to treatment with antibiotics. With or without nutritional supplements, they are effective in treating tropical sprue, which give us two options. Either this is an infectious disease with a full etiological unknown agent, or this might be multifactorial disease with involvement of an unknown etiological infectious agent. Small bowel bacterial overgrowth is observed in such patients, where the normal small bowel flora is predominantly gram-positive organisms in the upper small bowel. In tropical sprue, we will show increased number of gram-negative rods, including alkali genes, Enterobacter aerogenes, and Hafnia subspecies. This shift in microflora is one of the key diagnostic factors for tropical sprue. Environmental contamination with environmental factors that may contribute to increased small bowel microbial population. Third part of the pathogenesis is enterotoxin and inflammation. Gram-negative organisms isolated from the small bowel of tropical sprue patients have a secretory effect on intestinal cells, possibly through toxin production. EAEC is associated with malnutrition, persistent diarrhea, intestinal inflammation, and cytokine production, and we will see increased incidence of EAEC in patients with tropical sprue. Relationship with EED, we have a disease spectrum where tropical sprue and EED may exist on a spectrum of a single disease, or as being two manifestations of one disease. But proving this is still problematic since we still haven't detected the main etiological agent. And sprue is the more advanced and symptomatic form of EED. This is a hypothesis suggested by multiple people who disagree with them being two different diagnoses. This is one of the main questions in research community associated with these two diseases. There should be a sequence-based microbial identification which can help clarify the relationship between the two conditions. The factors influencing the abnormal bacterial colonization. First of all, low level of cytokines. Chronic parasitic infections in resource-limited settings may increase small bowel colonization of E. coli. Loss of protective mucin layer, where the damage to the mucin layer may allow tight association of bacteria within the mucosa and promote further epithelial cell damage. Intestinal immunological dysfunction, where patients with deficiencies of secretory IgA are more susceptible to enteric infections. Dietary factors, as long-chain fatty acids found in pork can alter intestinal motility and promote bacterial overgrowth. This affects the mucosal pH. Patients with folate deficiency have decreased absorption of folate in the gut, and this is one of the associated factors within the pathogenesis of tropical sprue. Therefore, we saw a correlation between these two diseases, where folate deficiency is a consequence of tropical sprue, where it leads to structural and functional changes in the gut, which contributes to venous atrophy and malabsorption, and altered water and electrolyte absorption. And then tropical sprue will even make it worse. So one of the suggested hypotheses is that folate deficiency and tropical sprue are kind of enhancing each other rather than one of them being the cause of the other. We have an association between tropical sprue and exocrine pancreatic insufficiency. This is by indirect tests that confirm these insufficiencies in patients with tropical sprue. It increases the impairment in absorption, which contributes to further intestinal dysfunction. If we talk more histopathologically and functional pathology, then the functional abnormalities within tropical sprue in the jejunum and ileum in tropical sprue. Here we observe the main damage. It exhibits a net secretory state, actively secreting water, sodium, and chloride, but the glucose-linked absorption is intact. In the ileum, malabsorption of bile acids and vitamin B12 occurs, leading to fat malabsorption and deficiencies of fat-soluble vitamins like D, A, K, E. Decreased function of brush border enzymes affect disaccharide digestion and absorption, for example, lactose absorption. And malabsorption of xylose, glucose, and folate minerals like calcium and magnesium, and amino acids may also occur. These malabsorption will further affect and excite the bacteria in our gut and lead to even increased osmotic gradient, which will lead to increased osmotic diarrhea. The loss of albumin in the damaged cell and the damaged small bowel complicates the protein metabolism. If we talk about the large bowel, limited studies have shown decreased water absorption capacity in the colon of tropical sprue patients compared to controls. Dysfunction of colonic cells may be related to excess fatty acids in the gut and lumen or bacterial toxin and infection originating in the upper parts of the GI tract. If we talk about hormonal dysregulation, we have dysfunction in the small bowel. We have reduced levels of postprandial insulin and gastric inhibitory peptide. We have increased level of enteroglucagon and motilin, and this increased gastric secretion and intrinsic factor secretion may also be affected and might give us extra symptoms, and this will lead to slowed transit time through the small bowel. And as we know, slow transit during the bowel leads to increased risk factor of typical bacterial infections. The histopathology of tropical sprue. As we said, we will have partial villus atrophy of the cells in the small bowel. This is the hallmark of our disease. These villi progressively shorten and thickens, forming effuse leaves after approximately 4 months of illness, which is almost a flat surface. This chronic inflammatory cell infiltrate, like mostly it's lymphocytic. This increased the mitotic index and megaloblastic appearance of crypt cells. We have increased numbers of globular cells, lipoid vacuoles within the basement membrane. But we have no convincing evidence of immunologically mediated disease. This refutes one of the hypotheses that argued that this disease have some autoimmune component. If we talk about EED, the consequence of continuous exposure to enteric pathogens via oral fecal route leads to intestinal mucosal inflammation and altered barrier integrity and reduced absorption. Dysbiosis alterations in the microbiome composition may contribute to dysregulated inflammatory response, impaired barrier function, and microbial translocation and inflammation. We have implicated mucosal immune responses and metabolic derangements. This is one of the hallmark differences between EED and tropical sprue, and it's one of the arguments used against the hypothesis of them being two manifestations of a single pathological entity. Talking about diagnosis, first of all, A travel and exposure history are crucial in diagnosing tropical sprue. Symptoms should include chronic diarrhea, weight loss, and evidence of malabsorption. If these three symptoms don't appear, it's not tropical sprue. Additional systemic complaints can be prolonged fever, jaundice, itching. These suggest alternative explanation for the illness, especially since tropical sprue and EED are purely intestinal pathologies. Diagnostic physical findings are non-specific, but they can include chelosis, stomatitis, glossitis, rashes, koilonychia, muscle pain, weakness, peripheral neuropathy, or edema. These are systemic manifestations of the complications of tropical sprue, which are malabsorptions and nutrient deficiencies, especially vitamin deficiencies. Laboratory evaluation may include complete blood count, B12, folate level, especially red blood cell folate level, serum carotene concentration, and fecal fat determination. Stool examination may be conducted to exclude giardia, while stool culture is less likely to be helpful in chronic diarrhea. We should test. Here we start an exclusion protocol. We should exclude giardia, we should test for HIV, and assess the likelihood of opportunistic parasitic infection of the gut, which is the hallmark of chronic diarrhea in HIV patients. Upper small bowel series with follow through and upper endoscopy with biopsy can aid in diagnosis of tropical sprue by looking at the histopathological aspects of our disease. Differential diagnosis should include, as we said, first of all, infectious agents. The infectious agents we should look at are giardia, cryptosporosis, coccidiosis, capillaris, and strongyloides. They are all either parasitic or infectious disease in specific populations. We can check for systemic illnesses like celiac sprue, lymphoma, blind loop syndrome, pancreatic tumors, Whipple disease, or microsporidia associated HIV enteropathy, which needs its own video. We should also check for intestinal tuberculosis, although this might be even more rare than our tropical sprue and will have specific additional symptoms that might indicate this being a tuberculosis, not a tropical sprue. But although when we take the biopsy from the endoscopic layer, intestinal tuberculosis should be tested for. Environmental enteric dysfunction. The diagnosis, especially definitive diagnosis, is the histopathological changes, and it requires small intestine biopsy. It is not routinely performed due to safety, cost, and ethical considerations. Some biomarkers are associated, but no one is currently available for diagnosis. These include the lactose to mannitol ratio to assess intestinal permeability, fecal alpha-1 antitrypsin to assess protein loss, and markers of mucosal and systemic inflammation. Other potential biomarkers might include intestinal fatty acid binding protein, but these are not tests that are ready available to clinicians. These are usually research department tests or developed research centers tests. We are talking about a disease that's primarily in underdeveloped countries. So theoretically, it looks beautiful, but practically, it's almost impossible. Fecal messenger mRNA transcripts for protein involved in immune activation and inflammation have been showed promise as biomarkers for EED, but as we said, too good to dream for. The therapy for tropical sprue. First of all, We can start by pathotropic and pathophysiological treatment, I'm sorry, is by compensating the malabsorption by giving folates. And combination of therapy with tetracycline is the most effective in resolving symptom and curing diarrhea with weight gain promotion. Sulfa drugs can be used as an alternative to tetracycline in children and pregnant women. If we talked about prolonged therapy, travels with tropical sprue, 1 month of treatment with tetracycline and folate is more than enough. For residents of the epidemic areas and endemic areas, 6 months might be needed or longer. If we talk about relapse possibility, even with prolonged therapy, relapses have been seen, especially in residents of endemic areas. The potential causes of relapse may be re-exposure to the infecting organism or recurrent disease rather than relapsing. If we talk about regional comparison, reports suggest that tropical sprue in the Caribbean is more responsive to therapy than sprue in India. But comparison between studies are challenging since too many factors go in to these two populations, and to correctly do a blind, fully observed trial is almost impossible. If we talk about diagnostic evaluation, in the lack of response to treatment, this should lead us to additional diagnostic evaluation, especially since one of the probabilities that no one excludes is the fact that we misdiagnosed our patient. And the tests to consider are small bowel biopsy repeated and antibodies to gliadin or endometrium testing. These are more sensitive tests and they can be available in capitals of underdeveloped countries. Treatment of EED is mainly nutritional intervention with vitamin A, zinc, glutamine, glycine, and multiple micronutrients. Probiotic and antibiotic treatment, especially with lactobacillus and rifaximin, show no significant difference in clinical or growth outcomes. We are talking about these two especially because these are the two most popular options in academic literature. If we give the patient L-alanine and L-glutamine, it improves the weight for age and weight for height, but not height for age. Albendazole have been observed, but with no result. And in EED, the biggest complaint of the patient is growth stunting. That's why when we look clinically into the effectiveness of any treatment, we look for improvement in these parameters exactly. Additional treatment approaches. For example, W3 long chain polyunsaturated fatty acids improve mid-upper arm circumference at 9 and 12 months. But this is now becoming too nerdy into the literature where no one will actually believe that this is actually working. We are living now in an era where proving that vaccines even work is becoming hard to ordinary population. So I don't see how a doctor can actually convince his patients with such treatment. But literature and theoretical doctors keep on giving us such options. And this is one of the main issues within tropical disease, where we have kind of a dissociation between the academic society that is more inclined to do academic work on the level of developed country and the practical aspects where the doctors and the population and the administration of these areas have bigger responsibilities of supply chains, of budgeting, of availability, of organization. That's why a more realistic option is azithromycin, which reduces the biomarkers of EED and is potentially useful for treatment. We have the wash intervention, which is water, sanitation, and hygiene. It has modest impact on stunting, but no significant effect on wasting or being underweight. And we have ongoing trials exploring other wash interventions. If we talk about nutritional interventions, the various nutritional interventions that have been attempted for EED is vitamin A supplementation, zinc supplementation, glutamine, glycine, multiple micronutrient, and the results vary. If we talk about probiotics, the clinical outcome showed no significant difference with probiotics and antibiotics, at least with the ones that have been researched well. We already talked about L-alanine, we already talked about albendazole and azithromycin. This concludes our video on our Tropical Sprue and EED. Hope that this video was beneficial and will help you later avoid the big probability of misdiagnosing Tropical Sprue and EED. And see you in our next video. This was the last video on disease of the gastrointestinal tract and intestinal infections. A video might be added about fluid treatment in these infections, and hope it was beneficial. Have a good day.